At the outset, I would once again thank the organizers for giving me this wonderful opportunity as a speaker to this prestigious occasion of Orissa Endocrine Society Conference 2023. And I definitely congratulate them for organizing such an academic extravaganza. So, my topic today is an area which draws increased attention and often forms the bridge between endocrinologists, nephrologists, and also physicians or whosoever is concerned with challenging areas in patients with diabetes who have certain kind of kidney involvement. So my topic here is suspecting non-diabetic kidney disease in a patient who has diabetes mellitus and also kidney disease, how we proceed towards solving this riddle. My talk would have broad outlines: the natural course of diabetic nephropathy versus non-diabetic kidney disease, the types of non-diabetic kidney disease that we normally encounter, the clues that will take us towards diagnosing a non-diabetic kidney disease, and what is the predictive value of diabetic retinopathy in a patient with diabetes and kidney disease in predicting whether it is a diabetic kidney disease or non-diabetic kidney disease, and what are certain retrospective studies and what are the final take-home points that we have here. Before we embark upon non-diabetic kidney disease, let's talk very briefly about the natural course of diabetes or diabetic nephropathy. Of all the microvascular complications diabetic patients suffer from, diabetic nephropathy is one of the most devastating and also one of the challenging complications, because these patients may eventually end up into end-stage kidney disease. And it's a chronic condition that develops over many years, which is characterized by gradually increasing albumin excretion. There is high blood pressure. There is gradually declining glomerular filtration rate. And of course, we have to make sure that other causes of kidney disease are absent, which we will see in our subsequent slides. And of course, the presence of retinopathy very often, but not always. Now, what is non-diabetic kidney disease? Non-diabetic kidney disease is a form of kidney disease in a patient with type 2 diabetes, but which is independent of factors caused due to diabetes. Essentially, it is a kidney disease in a patient with diabetes which is not caused due to diabetes-related factors. With the passage of time, non-diabetic kidney disease is becoming increasingly common, maybe because we are better managing type 2 diabetes and diabetic kidney disease these days with the advent of ACE inhibitors, ARBs, diet restriction with protein, and of course, in recent days with the advent of SGLT2 inhibitors. So the incidence or the total prevalence of diabetic kidney disease more or less remains same, but the incidence of non-diabetic kidney disease is gradually increasing. And all the more important to understand non-diabetic kidney disease because it has a significant impact in overall prognosis of the patient. Many times, diabetic kidney disease may not be an entirely curable disease, but non-diabetic kidney disease is often, if predicted at the right point of time, we may have a cure for non-diabetic kidney disease. As I was just telling, the prognosis, there has been a study where 3 distinct groups have been taken. One group who had entirely diabetic nephropathy, the second group had non-diabetic kidney disease, and a third group which had a combination of these 2 diseases. So whether we took at the initiation of the disease or 3-year or 5-year survival, across the different time periods, it was found out that patients who had got non-diabetic kidney disease had a better prognosis as compared to patients who had only diabetic kidney disease. And of course, patients who had both diabetic and non-diabetic kidney disease has the worst kind of prognosis. Now, as I just mentioned, whether it could be diabetic kidney disease or non-diabetic kidney disease as a cause in patients predisposing towards end-stage kidney disease. Our challenge is to find out how we differentiate and how we solve the riddle. So what are the non-diabetic kidney diseases that can be basically found in a patient with diabetes and kidney disease? You name it, you find it. Whether it's glomerular disease such as post-infectious glomerulonephritis, whether it's IgA nephropathy, membranous nephropathy, focal segmental glomerulosclerosis, diffuse proliferative glomerulonephritis, all these glomerular diseases, or sometimes rapidly progressive glomerulonephritis, all these kinds of glomerular diseases can be found in a patient with diabetes, but not diabetic kidney disease. Similarly, we can have non-diabetic and non-glomerular diseases such as acute tubular necrosis, acute tubulointerstitial nephritis, and of course, another important aspect is increased incidence of urinary tract infection, ischemic nephropathy, obstructive uropathy. So whether it's glomerular or non-glomerular, And these days, with the advent of, as I just said, better management of diabetic kidney disease or overall better management of glomerular diseases, incidence of or increase, we are finding more and more causes of non-diabetic, non-glomerular diseases as a cause of non-diabetic kidney disease. Now, whether there have been studies in India or abroad or across the world, the incidence of non-diabetic kidney disease varies from 40 to 60% in patients with diabetes and kidney disease. When we talk about the natural progression or the natural history of diabetic nephropathy, why do we need to understand? Because diabetes is a slowly progressive disease. The stage one is a stage of hyperfiltration. Then we have got a stage two, which is basically silent nephropathy. It is from stage three, which we have initial nephropathy. Stage four, of course, is the stage of overt nephropathy, and stage five when you have lost everything. And in other words, the patient has landed into end stage renal disease with advanced glomerular sclerosis. So normally it takes almost 5 to 10 years for a patient from the initiation of diabetes to reach a stage of microalbuminuria, say for minimum 5 years. These stages are very well defined in a patient with type 1 diabetes mellitus. However, the staging or the progression or the characterization of a patient into different stages is not so well defined in patients with type 2 diabetes, because often we are not sure of the exact time of onset of a type 2 diabetes mellitus. Approximately, as I told, most of the patients, in maximum number of cases, we found that it took around 10 to 20 years of duration between diabetes, with a progressive decline in incidence taking place thereafter. So, should you find a person who is having a faster decline in GFR, then probably it is not due to diabetic nephropathy. Now, as I just said, when it comes to type 2 diabetes, when we look at the different KDIGO stages, ideally, there should be a deterioration of albuminuria, then there is deterioration of the GFR. But some patients, as we can see, can have a certain decline in GFR even without typically progressing towards worsening stages of albuminuria. Some patients can have a regressive albuminuria. In spite of that, they can have a decline in GFR. Some patients can have decline in GFR very, very rapidly, otherwise unexplained by other factors. So in patients with type 2 diabetes, we find significant heterogeneity as far as the natural history of type 2 diabetes is concerned, because it is influenced by so many factors, whether it's hypertension, whether it is HbA1c levels, body mass index, and of course, presence of coronary artery disease, and whether there are other any extrarenal or extraneous factors present or not. So, can we deduce anything out of the rate of decline in GFR? We all know in patients in diabetes who are normal albuminuric, the rate of decline in GFR is 1 milliliter per minute per year. This normally is the same as the age-related decline in GFR. In patients who are albuminuric and are on treatment, the rate of decline is 4 to 5 milliliter per minute per year. But those patients who have got albuminuria who are not under treatment, it's usually more than 8 or so. The KDIGO also states that in certain subset of patients, when the GFR decline is more than 5, then they would term it as a case of rapid decline in GFR. So those patients who have got a rapid decline in GFR and some other indications which will give us a certain sense, or which will trigger us towards finding a cause for other factors or non-diabetic kidney disease in a patient with diabetes. So what are the well-established indicators? Absence of diabetic retinopathy. I'll come to it in my next few slides. Shorter duration of diabetes, microscopic hematuria, subnephrotic range proteinuria, and lower HbA1c levels and lower level of fasting blood glucose. What could be the potential indicators indicating towards non-diabetic kidney disease? There is no family history of diabetes. Patient has got higher serum protein or albumin. There is a higher level of hemoglobin. There is a higher level of serum creatinine disproportionate to the duration and staging of the disease. Lower blood pressure, abnormal complement levels, abnormal immunoglobulin G levels, and normal cystatin C levels. All these things can point towards can be clues towards going for a non-diabetic kidney disease. Now, one of the most common things that we do in our clinical practice, whenever we are in a dilemma, we send a consultations to our ophthalmologist to find out whether there is a fundus examination can give us diabetic retinopathy or not. But retinopathy, as an easily recognizable clinical manifestation, has always been very helpful to us. But can it definitely say that a patient, whether it's absence or presence, can it definitely guide us any further? What are the predictive values of diabetic retinopathy? When it comes to type 1 diabetes patient who has got albuminuria and retinopathy, the most likely the involvement of kidneys is because of diabetes. And also remember that with the worsening of albuminuria, the incidence of retinopathy also increases. In a patient who has got macroalbuminuria, it can be patient present around 60 to 65% of patients. In case of normal albuminuria, the incidence is around 14%. Now, various meta-analyses and also certain in our own country studies from Sankar Netralaya and certain CMC Vellore and SGPGI, all these centers have shown that the positive predictive value of diabetic retinopathy remains around 70% or 72% to be most precise, and the negative predictive value is around 69%. However, if there is a proliferative diabetic retinopathy, then the positive predictive value increases further to 96%. Once again, the correlation is better defined in patients who have got type 1 diabetes, and the correlation or the renal retinal correlation is not so well defined in patients who have type 2 diabetes. In another study, which was actually done over a period of 17 years, this was seen that up to 80% of patients without diabetic retinopathy eventually found to have non-diabetic kidney disease. In 80% of patients who had diabetes and some form of kidney disease who did not have diabetic retinopathy, the cause of kidney disease would turned out to be non-diabetic kidney disease. Conversely, 70 to 80% of patients who had non-diabetic kidney disease were found to have no diabetic retinopathy, were found to have an absence of diabetic retinopathy. So, as I just stated, the renal retinal relation in type 2 diabetes may be better asserted as the absence of diabetic retinopathy, reasonably pointing towards non diabetic kidney disease. Let me repeat this sentence once again. Presence of diabetic retinopathy may not conclusively point towards diabetic kidney disease, but an absence of diabetic retinopathy with presence of certain other indicators such as nephrotic syndrome, nephritic syndrome, or rapid decline in GFR, all these things with the absence of diabetic retinopathy can often point us towards a non-diabetic kidney disease as the most probable cause of kidney disease in a patient with diabetes and kidney disease. Another important factor is the duration of disease. Remember that if the duration is less than 5 years, most likely there could be some factor which is independent of diabetes. So there could be more pointing towards non-diabetic kidney disease. And if the duration of kidney disease appearing in a patient of diabetes has been after more than 10 years, then more likely it would be diabetic kidney disease. Why I'm telling all these things? Because in most clinical scenarios, we may not be able to go for a kidney biopsy. So these pointers are also very, very important. Another important factor. Now, this is an Indian study from Maharashtra, which they documented shorter duration of diabetes and the absence of retinopathy, especially when associated with nephrotic proteinuria, could predict non-diabetic renal disease. Now, hematuria is another indicator that points towards non-diabetic kidney disease. So, shorter duration, presence of absence of retinopathy, and presence of glomerular hematuria. If it is hematuria, and if we can be more specific, if it is presence of glomerular hematuria, then we would be more specific about the presence of non-diabetic kidney disease. This is another study which also points towards these factors. Now, we do not have any definite biomarker for diabetic kidney disease, although some people would say that TGF or vascular endothelial growth factor can be helpful indicators, but albuminuria more remains our everyday marker for diabetic nephropathy. But should we have to establish a diagnosis of diabetic kidney disease, then we'll have to resort to renal biopsy. So what are the definite indicators that we must do a kidney biopsy in a patient? Nephrotic syndrome without retinopathy, kidney function alteration without retinopathy, nephrotic syndrome in a patient with diabetes with a duration less than 5 years, and nephrotic syndrome discordant with the normal creatinine clearance because it must be first altered, and a cause of acute kidney injury that is not very obvious, And if there is hematuria that is unexplained and there is a rapid deterioration of kidney function, all these things should drive us towards finding a way to do a kidney biopsy and establish the diagnosis. Now, another thing that is often missed, we have to remember that the incidence of renal artery stenosis is also twice in case of diabetes as a cause of kidney disease as compared to non-diabetics. Acute kidney injury in diabetes as a cause of non-diabetic kidney disease could be due to various factors. It could be pre-renal, it could be acute tubular necrosis, it could be acute interstitial nephritis. And don't forget, urinary tract infection can contribute towards non-diabetic kidney disease. You know that diabetics, especially in case of when the incidence of asymptomatic bacteriuria is very high, twice as common in diabetic women as compared to non-diabetic women, and the risk is higher in women who are on insulin and who have a longer duration of diabetes. And of course, poor glycemic control only complicates things further. And diabetes not only causes urinary tract infection, it also causes complicated urinary tract infection, complications such as prostatic abscess, emphysemitis, pyelonephritis, and cystitis, intrarenal abscess, papillary necrosis, metastatic abscess, and ultimately septicemia. All these different forms of urinary tract infection can be present as a contributing cause towards kidney disease, or rather non-diabetic kidney disease in a patient of type 2 diabetes. Bladder dysfunction, age-related bladder dysfunction, because of autonomic neuropathy or obstructive uropathy because of diabetes, diabetic cystopathy, urethral stricture, papillary necrosis, all these things can also be contributing factors towards non-diabetic kidney disease in a patient with diabetes. We'll just look at a few of the retrospective studies. This is a Chinese study which was done from 2017 to 2021, which took over several patients. And the most common cause of diabetic in a histological examination, what is the most common finding in their cause as a cause of non-diabetic kidney disease? Then it was IgA nephropathy. And in another study which was done in India from SGPGI, Lucknow, over a period of a retrospective study from 2005 to 2022, almost a period of 17 years, more than 5,000 patients of biopsy were taken, out of which 538 patients had this diabetes, and they found that nearly 50% of patients had non-diabetic kidney disease, 30% of patients had diabetic kidney disease, and 20% of patients had both diabetic kidney disease and non-diabetic kidney disease. So that will combine around 70% of patients who had got both diabetic and non-diabetic kidney disease. Now, why is this incidence of non-diabetic kidney disease increasing, and why? What is the changing paradigm in these patients? What are the different types of non-diabetic kidney disease in these patients? It was found that in their study, acute tubular interstitial nephritis was much more common as compared to other studies where IgA nephropathy and membranous nephropathy were more common. Probable factor because the factors that drove them towards doing biopsy, or the indicators for kidney biopsy in these patients, was a deterioration of renal function. So in those patients who had got diabetes, kidney disease, and AKI, probably acute tubular intestinal nephritis was more common. However, in those subset of patients who did not have acute kidney injury, still IgA nephropathy and membranous nephropathy were more common. So when we come to our final few slides, I think we'll be going for our conclusion. And remember that not all kidney disease in patients with diabetes are diabetic kidney disease. Non-diabetic kidney disease can be a significant factor in patients, and it is very important to understand, diagnose non-diabetic kidney disease, because non-diabetic kidney disease are often, we have better tools for the treatment. Diabetic nephropathy doesn't have any specific therapy. So identification of all causes that are non-diabetic gives us an opportunity to treat and reverse the condition, and thereby reduce burden of CKD, which is one of the most important objectives in our entire endeavor. With that, I thank you once again, and thank you for giving such a wonderful response to my book, A Destructed World, which has sold over a few thousand copies on Amazon and making it a bestseller. Thank you once again.